members of Congress. Unique privilege of being the last speaker of the session. So, my task has already been released by these two speakers, Rao and Saranya, and now I can skip certain slides because I have slides for what required. This has already been explained. What is the mechanism of sarcopenia? There is portal hypertension, catabolic state, and synthetic function is impaired, and there is low-grade chronic inflammation that will lead to progressive deconditioning and immobility is responsible for decreasing vulnerability to health stress. So, in presence of that, there is higher risk of decompensation in form of ascites, hepatic encephalopathy, and this worsening clinical condition may lead to liver-related events, death on wait list, and even after transplant, the post-transplant outcome is not so good in patients with sarcopenia or depression. So, here I will say that increased risk of liver decompensation related complication include ascites, encephalopathy, infection, and it worsens both sarcopenia and frailty, and post-transplant both are associated with increased risk of morbidity and mortality. So, what are the consequences of sarcopenia? There is increased risk of hepatic encephalopathy, infection, sepsis, hepatocellular carcinoma, and has a negative impact on quality of life and poor outcome from liver transplant. There may be increased hospitalization, prolonged ICU stay, and longer duration of incubation. There is increased hospital cost, almost double in sarcopenia. Same way, frailty also impacts healthy outcome. That besides pre-liver transplant, frailty is significantly associated with post-liver transplant mortality, quality of life, resource utilization, ICU stay, incubation time, and hospital stay. So pathogenesis has already been explained, and in fact, based on that, we can decide where intervention is possible. As pointed out in the previous lecture, that ammonia is considered as a main driver of sarcopenia in liver disease. But I have my own opinion. In fact, there cannot be one driver, and for sarcopenia, there are multiple drivers, and that depends on the situation and condition also. So it cannot be one size fit all approach while dealing with the patients of sarcopenia, even in liver disease. So there are many areas where we can intervene, and I'll come to that one by one, because what happens? There is portal hypertension, so we can tackle portal hypertension that will have an impact on sarcopenia. We can lower the ammonia level by intervention, by lowering ammonia. The main thing is that one thing which has been pointed out in the previous talk also, that myostatin is the main driver, because myostatin, if it is upregulated, myostatin B, that will inhibit muscle synthetic pathway, that is mTOR pathway, and it will also stimulate autophagy pathway. Not so much of impact in ubiquitin proteasome pathway, but autophagy pathway is definitely increased. So once it is upregulated, there is less of muscle synthesis and more of muscle breakdown, because satellite cells are also depressed. So that is also one important point one has to keep in mind, that ammonia has effect on various levels. So that I will come and in my talk there I discussed that point also. And there are certain hormones which are, their level is decreased, especially testosterone and insulin like growth factor, which has been studied. Now, despite knowing all this, very few trials are there where we have shown some improvement with the intervention in case of sarcopenia. I'll discuss these. So there are certain interventions which are well established, like nutrition support and exercise. Doubtful role of branched chain amino acids in sarcopenia, and there are certain emerging interventions like Lola, L-carnitine, insulin like growth factor 1, testosterone, polystatin, and terlipressin before we had mentioned. And there are others which are still in the process of using, like vitamin D, because human studies are very limited with these agents. So nutrition prescription is a standard. I think I can skip this. You just have to assess the nutritional status, and then you can give calories. Non-obese patient, 35 kilocalorie per kg. In obese, depending on BMI, you can reduce calories and increase protein. That has already been discussed. And then one thing very important: cirrhosis is a state of accelerated starvation and anabolic resistance. So we try to keep fasting period to the minimum. That we can do by giving a small frequent meals at the interval of 3 to 4 hours, and a late evening snack, and early breakfast. That is very important. That has shown some benefit. So this is the concept, because we want to keep this fasting period to the minimum. Because if it is long, then the process breakdown will start. The calorie, because carbohydrate will be utilized first, and then there will be protein breakdown. Means gluconeogenesis will start, and muscle cannot utilize fat. So amino acids will be utilized for synthesis of glucose, and that way there will be protein breakdown. So we want to keep it to the minimum by giving late evening snack and early breakfast. Coming to branched chain amino acids, this is again a randomized controlled trial. 32 patients with cirrhosis were given branched chain amino acids, and sarcopenia was assessed by SMI, and 17 patients were there in the placebo arm, and 15 patients, 12 weeks intervention was given, and then they have shown that there was some improvement in the muscle mass. This is our own study, randomized controlled trial, again with adequate sample size. 60 patients were randomized, and a 6-month intervention was given. But we are surprised there was no change, neither in muscle function or muscle mass. This is a negative study. This is again another study, 54 patients, where this was given, and there was improvement in SMI and LFI. This is a recent study, but again, there is controversy. These are again, this was a study from Jaya's group. In fact, they have shown some improvement, but I am not very sure, because here the change is seen in both the groups, even in placebo. So they all were doing exercise, they were taking good nutrition. So these changes are there. We gave intervention in one arm, but the changes are there in both the arms. So we can't say that these changes are because of intervention, right? Branched chain amino acids. These are various meta-analyses with conflicting results, so news is still not out. Whether branched chain amino acids are of any use or not, we can't say. Here, this is our own data where we have shown micronutrient deficiency, but we can't say whether by giving micronutrients we can improve the condition. Okay, we can improve the condition. But definitely there was deficiency of micronutrients in cirrhotics, and that increases with the severity of the disease. Coming to the role of exercise, again, by exercise we can improve the muscle function to some extent, and that is why this is important. But before that, we have to rule out certain things. If patient, first we have to assess the safety. If patient is having high risk varices, prophylaxis is needed. If patient is having hepatic encephalopathy and ascites, then it should be optimized and should be done under supervision. And then cardiopulmonary safety screening is also equally important before advising an exercise. This is the prescription. The frequency: aerobic 4 to 7 days per week, resistance exercise 2 to 3 days per week, intensity again on dog scale 3 to 5. Time: aerobic 150 minutes per week, and resistance 3 sets of 10 to 15 repetitions. Type: aerobic, like walking, I will show, and a combination of resistance and endurance exercise have the potential to lose weight and exercises you can advise to the patient. And then these are the various studies there that have shown that in compensated patients, exercise program 8 to 14 weeks plus nutrition results in increase of muscle performance and muscle mass. Again, the same thing, there was no significant impact of fat mass and BMI and quality of life in 8 studies with 220 patients. What are the emerging therapies? Rifaximin and lactulose I will not discuss because it's known it's used in nephropathy mostly. Lola, carnitine, hormone therapy, myostatin antagonist, and total pressure lowering agents along with nutritional supplement. Vitamin D, probiotics, again, they are very limited studies, so we can even skip this. As far as ammonia lowering is concerned, L-ornithine aspartate has been used, and 4 weeks of therapy result. I can see the person whose paper is this. He's there in the house, and what they have shown in an animal study that hyperammonemia increases myostatin expression in the muscle and decrease mTOR, increase autophagy, and that has reversed in patients those who are treated with treatments. This is a clinical study. 34 patients. Lola was given 6 gram TDS, and another placebo group of 22 for 12 weeks. 100% skin fold thickness and cysteine block test was performed. Biceps skin fold thickness showed a mean gain of 1.5 millimeter in Lola group and a mean loss of 1 millimeter in placebo. So there was definitely gain in this study. Now coming to L-carnitine, it is a naturally occurring compound synthesized in the body from amino acid lysine and methionine and found in various food products, especially meat and dairy products. It has a potential role in reducing ammonia level and improving symptoms of nephropathy. It helps in transporting long-chain fatty acids into the mitochondria. So these are the various studies with different doses, and what we have shown, meta-analysis of 5 studies have shown there was no beneficial effect on BMI body weight. At present, results are not developed. Now, coming to testosterone level, it has been shown that in patients with sarcopenia and heredity, that level is low in various studies. It was more frequent among frail patients and lower serum testosterone level in sarcopenia than in non-sarcopenic patients, and muscle mass is correlated with ST level. This is a study, double-blind placebo-controlled trial with 12-month duration intervention with testosterone was given. This was studied by Sinclair Group, and they have shown that testosterone therapy in cirrhotics with low testosterone level is safe and increases muscle mass. But then we have to be extra careful because there is a risk of developing HCC and thrombosis. So we have to be very careful, and it should be given at this speed. These are other 2 studies. So nutrition, exercise, and testosterone was given for 6 months intramuscularly, and there was an increase in appendicular lean muscle mass by 10% and improvement in stability and bone mass. There was reduction in fat mass. This was by intramuscular injection, and this is another study where they have shown improvement with oral testosterone. But then these are all very small studies, larger randomized controlled trials. Insulin like growth factor again. This was another study in 19 alcoholic and primary biliary cirrhotic patients. They were randomized in 2 groups, and it was given. Insulin like growth factor therapy increased significantly the serum albumin significantly, and they were short course increases albumin level and then improve energy metabolism. I can skip many. Like cholestatin is a positive regulator. It inhibits effect of myostatin, activin, and GDF11. It suppresses SMAD3 and reinforces ATP phosphorylated on mTOR pathway. And so, but this is an animal study, so again, I think from Dasarati group where they have shown that by treating these animals with cholestatin, there was decrease in myostatin level, and myostatin is inhibited, and there was increased expression of mTOR. Now coming to hypertension, times are running out. We can can I take 2-3 minutes extra? So what happens in focal hypertension? There is intestinal dysfunction. Not only that, there may be barrier function is also affected. So low grade inflammation is there, and then this will lead to increased protein energy malnutrition, and then by reducing protein pressure, what we can achieve, we can correct impaired digestion and other function, and potential to enhance the nutritional status is also there. Sarcopenia can also arise in individuals without cirrhosis. That is why we say that focal hypertension per se may lead to sarcopenia and other function, not only in cirrhosis, but otherwise in non-cirrhotic fibrosis also. So, what we can do? There are studies in which they have shown that 30% can improve calorie intake, as well as they have also shown that improvement in nutritional status and muscle parameters. This is again various studies, and they have shown that there is increased muscle mass and fat mass in the chain. Then after tips, in fact, tips have already been covered. This studies when covered, I can skip. Then beta hydroxy beta methyl glutamate. This is another compound which has shown some promise that mode of action is same. It increases protein synthesis, tissue repair, and aerobic performance. So if ubiquitin proteasome system is activated, so it is also a naturally occurring metabolite of leucine and has an anabolic effect and used as dietary supplement. These are the studies, small studies, and it has shown some promise, but definitely more trials are needed. These are the future agent. Vitamin D has already been discussed, and I will skip this. And this is our own data where we have shown that in cirrhotic, sarcopenia and osteoporosis they are present simultaneously. The patient has osteosarcopenia, that is one term which I find for these patients, and in them outcome is poor. But the vitamin D supplementation, this is again a randomized trial in which we have shown that there is no significant change even after 1 year intervention with vitamin D and calcium. Probiotic, again in our own study, we have shown that in both NAFLD and ALD, gut microbiome is found to be altered. There is reduced alpha diversity and reduced to bacterioid ratio. These are the studies where they have shown that by giving probiotics, we can increase good bacteria in the gut. That will lead to restoration of barrier function to some extent. And this is the effect of probiotic on muscle. The effect of probiotic on muscle has shown improvement. And then coming to the summary, sarcopenia and sterility pose significant challenge for management of cirrhosis. Current landscape involves dietary and lifestyle intervention, and emerging drugs are DOLA, tranexamine acid, carnitine, testosterone, cholestatin, and terbitalin. And ongoing research is exploring new avenues like vitamin D supplementation programs. Thank you.
Thank you, sir. It was an excellent talk as always. I request you to have